Now, I know, Mike said I could just say hi, Mike, to introduce him, but we will not do that. For those of you who don't know, Dr. Wolf is a health services researcher with over 20 years of expertise in aging, chronic disease self-management, health literacy, and design of health system interventions to promote health, particularly among more medically complex older adults living with multiple chronic conditions. For the past 2 decades, he has led studies investigating individual and health system determinants of health service use and outcomes, and the effectiveness and fidelity of interventions aimed at helping patients better engage in healthcare and self-manage chronic conditions. In 2019, Dr. Wolf was named founding director of the Feinberg School of Medicine Center for Applied Health Research on Aging, or CAHRA. CAHRA seeks to promote informed decision-making and actions leading to optimal health and well-being among individuals and families over the lifespan. As of 2020, Dr. Wolf is the director of Northwestern University's Claude D. Pepper Older Americans Independent Center, focused on primary care innovation to improve the management of more complex older adults with multiple chronic conditions. So thanks for being here today, Mike, and looking forward to hearing your talk.
Thank you, Sarah, and happy to be here. I'm going to mostly talk a bit about some of the work that we've done, and good to see a lot of friends on the call here too. So, what I'm going to also talk about today is a research agenda that reflects not just my own, but a lot of our team members. So hopefully this is just kind of a way to showcase, I think, a continuing strong research agenda that I'm hoping we can continue to press forward. So, pardon me 1 second as I'm having some issues with advancing. So real quick, just want to give also a quick shout out to again, this has been now going on we'll be moving into starting our 3rd year of doing the Northwestern Pepper Center Grand Rounds. And this has been kind of, again, I'm sitting in here today, but most of this venue has been really focused on showcasing the research across the Pepper Center network. And it was a way for us as one of the newer Pepper Centers to quickly get to know our friends across the country and other institutions that have a Pepper Center. And we also greatly appreciate the support by the Wake Forest Coordinating Center, who's been very, very much an advocate for this work. And so please contact Eleanor if you also have someone to nominate that we should be reaching out to these talks, or if you yourself would like to be showcased in this manner. We really appreciated it. And again, it's been heavily focused on health services research and outcomes research as well. So, and there's our tags for our, please follow us on X, formerly Twitter. Big thank you, because I am not in my home office today. I'm actually at the University of Iowa, and just wanted to highlight one of our friends who former MCC scholar through the Aging Initiative with Jerry Gerwitz and Jay Magaziner at Maryland. We met through the National Coordinating Center meeting, and she's graciously hosted me here today so I would have a venue to do this talk. Some quick disclosures. And also, this is our team effort. So a lot of the research I want to highlight, everybody here is really working on our cognitive aging agenda here at the Center for Applied Health Research and Aging, and a lot of the projects I'm going to showcase today. And so all of this is the work of many, not just one or a few. So thank you. And also, as another shout out to the Wake Forest Pepper Center, our newest member, Abby Vogley, who actually trained at Wake Forest and worked with Dr. Fanning at the Wake Forest Pepper Center, is now our new doctoral student in neuropsychology with our group. So we're very excited to have Abby on board too. And we have many contributors from multiple Pepper Center institutions, as well as many others that we've worked with for the projects I'm going to be talking about today that I also want to give a quick acknowledgement for. So the topic, and the very, very long title, my apologies, is really kind of reflecting of work that we have loosely defined as applied cognitive epidemiology. And I'll kind of go into briefly in a moment what that means and how that kind of came about, because it is a recent field. And the investigations I'm going to be talking about are really reflecting ways to think about cognitive decline and how we might modify risk of slowing cognitive decline and eventual impairment and dementia, as well as the work that we've been doing with our collaborators here at Northwestern and others across the country on improving detection, specifically in primary care and other everyday clinical settings, and also enhancement of management. So once you do have a suspected impairment, or notable cognitive decline that may be impacting self-care, how can primary care specifically be mobilized to help? And the projects that reflect risk I'm going to be talking about include a few. And so many of the team members you saw in the earlier slide are working on projects. First on LitCog, a project that's been going on for many, many years that continues on, funded by the National Institute of Aging. And then it's a sister grant that was more recently funded on MidCog that I'll mention in this talk. And then a very disease-specific focus of the work that we've been able to collaborate with longtime partners at Penn on the project of LiveCog, led by Julia Yoshino Benavente, who's also our Associate Director for our Pepper Center. On improving detection and enhancing management, again, our collaborating teams across Northwestern relate to a National Institute for Neurological Disorders and Stroke initiative called Detect CID that'll also kind of be the second half of my talk today, and thinking about the work that could be done there moving forward. So if you'll go down the rabbit hole with me a little bit, we will get pretty specific on some of the work that we've been trying to get at for, again, this is now a 20-year agenda that our team has been engaged with. And the terms that I'll be using quite a bit, we think about cognitive abilities, which really kind of reflect just in general across maybe a general population, thinking about, individual differences in a range of cognitive skills. Then we think of oftentimes cognitive function, or what sometimes people refer to as cognitive dysfunction, which may be more of a clinical label in terms of thinking about someone having adequate skills in the context of their health. And then thinking more about cognitive decline, whether it be normative or relative, and then ultimately impairment, which is going to get to a little bit of the work that we're talking about now as we start to think about, our work in the larger portfolio of NIA's and Alzheimer's disease and related dementias work. So cognitive epidemiology, really the first time we heard the term, and I believe it's the first program in the world that was actually kind of created as a doctoral program focused on cognitive epidemiology, came out of our very, very dear colleague of many, many years who helped really launch a lot of my work, is Ian Deary. Ian is both a physician and psychologist at the University of Edinburgh and has been there many, many years. And his work with the Lothian birth cohort study has been really unique. And it really has been focused again on examining cognitive abilities. And in the way he interprets it, which we take a little bit of a different take, is focusing really maybe ways around thinking about intelligence and how that relates to morbidity and mortality. This is the Lothian birth cohort that I just mentioned on the steps of the library at the University of Edinburgh. This is a very unique cohort that I'll just take a moment about, that was really one that really launched this kind of field in many ways. Just as a quick backstory, Ian, just having finished his MD and PhD and starting his new position at the University of Edinburgh, found in the basement of the psychology department back in the 70s, boxes and boxes of Webster intelligence assessments that were mandatory for all third graders in Lothian County, the greater county outside of Edinburgh. And basically, he was then, as funding from the NHS in England, and the United Kingdom, created this cohort by finding these individuals who at the time were, in their late middle age, and started to track them over time and looked at childhood intelligence and how it impacts later life health, and also how it relates to later life intelligence. So of interest, as you might see, the picture in the corner was actually featured in there's a whole story in Science that shows Ian actually administering the Webster Intelligence Assessment to Queen Elizabeth, who recently passed. So this has been a really, really unique cohort. There's very, very few studies that have been able to really look at cognitive function across the lifespan, and he's been able to do amazing studies with it. So Ian has, again, been able to look at primary, targeting really individual differences in age-related cognitive decline. The original focuses were really on thinking about specific cognitive domains and how they impact health. And so some of his earlier work was like really trying to say, is there a specific set of cognitive abilities, whether it be working memory or aspects of reaction time or processing speed, that could relate to specific aspects of health outcomes? And really what he eventually shifted to is what's more called as a G factor, or a general ability, because recognizing that a lot of cognitive functions actually all correlate very strongly to one another. And that's where his interests were more, focused on more larger intelligence and how that really kind of affects mortality risk and also morbidity. Some of the work to date with him has really kind of highlighted that childhood IQ, what he calls pre-old age, that being age before 70, and the change before age 70 across in cognitive function and how much movement there is, as well as later life IQ. All risk factors are for more rapid declines in cognitive abilities, and ultimately presented as risk factors for cognitive impairment and Alzheimer's disease and related dementias, or what I'll later call ADRD. And he's also been studying, his team, his cognitive epidemiology program has been studying genetic, vascular, environmental, including both social and physical, as well as lifestyle causal mechanisms. And where we differ a bit in our group at Northwestern has really been focusing on self-management capacity. And it's really been less on trying to understand how individual differences impact longevity, so much as understanding that what do we ask people to do in engaging in the healthcare system, and recognizing that sometimes it's what we're asking them that might actually cause challenges. So when we think of self-management capacity, a lot of our investigations, especially in non-impaired adults, when we're thinking about maybe age-related cognitive decline, there's a lot of work already that suggests that socioeconomic disparities and inadequate self-care behaviors are likely determinants of risks of cognitive decline and impairment. And kind of the modifiable self-care behavioral factors that we're really looking into are things like timely detection and treatment of chronic conditions, and that includes behavioral health, including depression, identification, correction of sensory impairments, adequate treatment adherence. So even if you have a chronic disease, how well are you having it managed? And that includes routine healthcare engagement. Lifestyle factors, including physical activity, smoking, alcohol use, and stress, are all aspects of the Lancet Commission in terms of risk factors that we know to be having sufficient evidence, or at least maybe not sufficient, but growing evidence of having contributions to risk of later cognitive impairment, dementia. And there's also sleep health, which I'll talk a bit about, because that's something very, very new to me. And we're very excited to work with our collaborators, Minji Kim and Phyllis C, on that regards. But the way they think about sleep is not just in kind of being very isolating about sleep apnea or insomnia, but thinking about duration and timing and pattern and efficiency and quality. Again, things that I've been learning through working with our circadian and sleep medicine center here. A lot of our work now also is focusing, as you can see by the modifiable targets that we just mentioned, is to really think younger, thinking about midlife, and thinking about that right now there are fewer cognitive studies that have included middle-aged adults and have well characterized them across cognitive domains, as well as other aspects of lifestyle and health behaviors. And I can think of a few, including Cardia right here at home, but MIDAS, the Whitehall 2 study, and Dunedin in New Zealand have been a few. But again, overall cognitive aging studies have tended to target populations where cognitive decline has already begun. And for us to think about prevention, that's where a lot of our work is now focused, to go younger. A lot of our work also, it really kind of is centered around the confluence of increasing health needs that come with age, as well as the time that's at a time when you're seeing more declines in cognitive resources that you have to address them. So, right now we're talking about the 65 plus population, ranges anywhere, estimates range from anywhere from 64 to 80% in terms of adults who have 3 or more chronic conditions. And then when you look at the image on the right, Lindsay Kabayashi, who I believe now is at Michigan, a former colleague of ours, did some work with our team to really start to kind of highlight things like cognitive ability, which we know pretty well, the fluid abilities decline with time, those abilities that help you actively learn and process and maintain attention, all the things you'd want to do when you're engaging in a healthcare system, talking with providers and managing your personal health. Those in health literacy all show, considerable declines, across the lifespan. So as you're seeing those things, those skill sets that you need to kind of manage a chronic disease, that's when they're also starting to kind of dissipate and making it more challenging. This is an interesting paper from Schultz and the team, Ash Tikal's team at Case Western, that have done a lot of work at trying to identify specific combinations of multiple chronic conditions that have, in terms of their prevalence, their cost to the healthcare system, as well as what really impacts function and health status over time. And, some of the things that for us, it's interesting because it's about deconstructing what does it mean to be a patient. And when you start thinking of the chronic conditions that require, or at least have the greatest impact on function and health status over time, when they're included either alone or with other, maybe less impactful chronic conditions, or in combination, like diabetes, COPD, arthritis, and general cardiovascular disease, all show to have the greatest impact on health status. And the question just begs to be, well, what does it mean to have be a patient with diabetes, and what exactly is being asked of you is and to assume that patient role in terms of managing and monitoring your conditions and engaging in the healthcare system? All of it can be quite formidable. So when we think about, our first study among older adults called LitCog, that's been going on for quite a while, where we've been following patients every 2.5 to 3 years, our thinking first was watching cognitive function and its decline and how that impacted one's ability to engage in health, to access and use healthcare services, to interact with providers, to self-manage and maintain a healthy lifestyle, and how that ultimately would impact health outcomes. And so a lot of our research to date has been looking at cognitive function as really kind of the determinant of health outcomes in older age. But now our focus has also been thinking about, well, what's happening in midlife, and thinking about how one currently accesses healthcare, interacts with providers, self-manages their health, maintains a healthy lifestyle, as well as the impact of psychosocial stressors and other factors that is determining cognitive function in later life, to kind of create this kind of cyclical kind of event. And so we're thinking about the life course and what we could be doing earlier on to preserve our cognitive function. And then also, once you have maybe on a more rapid decline of cognitive impairment or even dementia in later life, how do we help patients continue to manage all the multiple chronic conditions that they may have to preserve health and well-being and function? So with our studies, both MidCog and LitCog, a lot of our investigations are focused on trying to really examine trajectories in cognitive performance, and specific by domains. So again, trying to do this deeper cognitive profiling. So not just thinking about just crude global function, but can we start to understand a bit more what aspects of cognition are declining at a more rapid rate, and if that differs between patients and also by multimorbidity. We also assess, which is kind of unique to our studies, objective performance on everyday healthcare tasks. I say that's kind of unique, but I would want to give credit to Denise Park and Shelley Willis, cognitive psychologists, that back in the early 90s were starting to really do this, asking patients to really start to understand how well can you do some of these tasks. And I think that's really informative for us, because sometimes what we ask people to do, whether you even think of something as dynamic as taking medication, it's oftentimes not clear in how the instructions are provided to how you can engage in these tasks. And also the tasks themselves could be done in a maybe a more efficient manner, but it may be the health system that's actually kind of creating some of the confusion. So we tried to come up with replicable tasks that would be evident of what you would see in a typical health system when we ask people to kind of examine how they take medications, recall information from medical encounters, engage with online multimedia materials, and so forth. We also assess health and lifestyle behaviors, patient-reported outcomes, and have full access to their medical records and pharmacy records in some cases too. The interesting thing about our studies too, we've sought to actually make sure that they're diverse by race, ethnicity, socioeconomic status, and comorbidity, which has not have been the case historically in cognitive aging studies, especially those that are done outside of the US. I'm not sorry for the very, very small image. I don't expect you to really delve into it. I think if anything, the image just says that we do, this is a very well-characterized cohort. We've got 3 currently. We have LitCog, which has been recruiting since 2007. Again, assessments every 2.5 years. We are on our 6th time point to date and getting for our renewal. We have 900 health individuals that were cognitively normal at baseline, diverse by race, SES, and comorbidity. Again, we have full access to the EHR, and they were 55 to 74 when they started. So they're now in their early 70s and pushing late 80s, early 90s in the cohort now. LitCog caregiver, again, I want to give a acknowledgement to Rachel O'Connor on our team, who leads a large research agenda right now on caregiving, and really trying to understand not just the impact of caregiving on the care partner, but what is the benefit of a caregiver in maintaining the independence and function and well-being of the patient, and looking at their health literacy and self-care capacity. Because as I've learned from working with her, the role of caregiver oftentimes is thrust on an individual, maybe oftentimes without a clear understanding of what that role means. And finally, we have the mid-cog cohort that I've mentioned, which launched in 2022 and is still ramping up. We're getting close to halfway, and it's harmonized LitCog, so we'll be able to study patients across the lifespan from ages 35 to early 90s to examine some of these relationships. So this is that Scottish cohort I showed you before, the 36 Lothian cohort. We are proud to have, this happened at our 10th anniversary, our LitCog cohort, where we were able to kind of replicate kind of our group. Our group is much more diverse, specifically in terms of comorbidity. Again, our sample is more community driven in its recruitment. So we're very proud of our group and that they're maintaining right now. We've also been able to take LitCog, again, this idea of understanding how cognition changes over time and how that impacts one's ability to manage chronic conditions to a very specific case. And this is led by Dr. Marina Serper, and she's at Penn. She was with us at Northwestern for a while and is one of our closest collaborators, and some of the great work she's doing with us that we're happy to be a part of is focusing on something very complicated like liver disease. And those who are receiving transplant, with sometimes there's expectations that once you have been transplanted that you may return to a stable, maybe a cognitively normal state, and you're able to, soon after a liver transplant, manage your self-care adequately. And so the idea here is to really understand if that's true, and to also really maybe, again, do more deeper cognitive profiling to understand exactly how the impact of a transplant might actually affect cognitive function over time. We're working with Daniela Laudner, who at the Transplant Center here is one of our close colleagues as well, is to consider this also in kidney. A lot of our work out of LitCog in particular has really started to understand that just in some ways, this is also part of the larger health literacy research agenda that's gone on for 3 decades plus now, that has kind of really highlighted that some of the most basic things that we push out to patients can be actually complex, and not necessarily so because of the way the task is presented to patients. So everything from looking at quality of colonoscopy preparation to being able to recall 15 minutes after a medical encounter, everything that a doctor said, pathophysiology, diagnosis, behavioral recommendations, new prescriptions, all of this can be very, very challenging if we aren't properly supporting people through the task. So this is not about showing like my colleague, Dr. Deary, was, looking at intelligence and individual differences. This is about focusing on the test, not the performance on it. How well do we allow patients to engage in the healthcare system, and how do they actually successfully or not perform the very common tasks that they would be expected to perform in their role as a patient? What we found fairly consistently, and this has been also replicated in other studies too, is that poorer fluid cognitive abilities over time, and that's those aspects of cognition that we do apply to take on new information, to process that, to multitask, to hold attention. That if we see poor comprehension, recall of not just print but online and spoken health information and instructions. We see and have reported on medical dosing errors and poor adherence to treatment that oftentimes goes undetected because there's really no good clinical signal in most primary care practices, at least, of proper adherence, although that's changing a bit now with electronic health records. Unintentional non-adherence to procedural device instructions, lower uptake of meaningful use of patient portals and telehealth, demonstrated problem solving, inadequate healthcare problem solving, we've also shown that patients with poor cognitive abilities, or at least poor health literacy, are more likely to avoid medical care out of concerns of what the doctor might think, variable control of chronic conditions, and worse physical and mental health. And in our sample, in our LitCog sample, up to nearly over a third of our participants have transitioned over 12 years to some form of cognitive impairment or early stage dementia. And yet less than a third of them have been detected timely in primary care. So coming back to this, if it's not so obvious already, why are we studying this so much? And it's more of a health services research angle to cognitive aging studies, because really navigating healthcare is painful. And a lot of it is unnecessarily so, as I've said before, that, I think the focus of a lot of our research has been trying to understand how patients currently engage in the healthcare system, what's easy, what's not easy for them, and recognizing that any healthcare system, for the most part, is going to have a very diverse consumer audience by thinking about their health literacy skills, their prior healthcare experience, in other aspects that might affect how they think and their beliefs about health and healthcare and what their role should be, and how they should be engaging in healthcare and communicating with healthcare providers. So from that end of it, our understanding of what people are struggling with in managing their health is helping us to think about healthcare systems and how we can actually do a better job to accommodate the diversity that we do see in our patient population. And for us, that's more directing attention to the user interface of healthcare. And there's strong emerging evidence based on best practices tailored for older adults on how to do that. In fact, our team, our Pepper Center, has a design core specifically led by David Moore and Andrew Berry that is really gearing up to understand how can we really document and collate all of these best practices, so we can think about from an aging perspective, how should we be thinking about the design and push out of healthcare services. We're also trying to create opportunities to keep patients and care partners more engaged over time between visits beyond the point of care. And that means leveraging technologies, often multiple modalities, and helping patients at their own preference remain engaged and providing feedback back to providers so they can be more proactive in responding to patients' needs. And thirdly, we're also trying to think about how can we possibly identify or classify individuals at risk. And that's not just about screening for cognitive impairment, which is going to be the next part of my talk, but also thinking about other things that have been discussions for the past 15 to 20 years. Are there other vital signs that we could be considering, including lower health literacy or lower health activation, which is actually something that is health insurers have been thinking about for a long time as ways to identify individuals who might be, if found at risk, given more resources, because those are the individuals that may need longer visit times, more frequent follow-ups, more confirmations that patients understood what their medical instruction should be, especially around issues with transitions in care. So switching gears, because of that last note about how do we start to detect individuals at risk, I wanted to focus on some activities we are doing right now with our great colleagues over in medical social sciences at Northwestern, and also working as part of a national consortium abroad called Detect CID. And so in thinking about cognitive, whether it's impairment or cognitive decline, thinking about its detection or management, we have been doing quite a lot of work since 2017. That was the launch of the National Institute of Neurological Disorders and Strokes, Detect CID, or a consortium for detecting cognitive impairment, including dementia. There's been a big push, again, back thinking about our home and primary care is kind of the focus for us, about how do we mobilize primary care practices, diverse practices, in fact, that are oftentimes resource constrained, have diverse patient populations, and therefore are going to be challenged to kind of be on the front lines in getting any cases of cognitive impairment or dementia detected at an early enough stage where you can better maintain one's function and independence for a longer time, and also engage in care planning with family members and so forth. So we know that, especially with the Alzheimer's Association, there's a lot of benefits for earlier detection, and primary care has been a target for NIH for some time. Was fortunate to be asked to be part of the Alzheimer's disease-related dementias summit in 2022 when they were revisiting recommendations from the Multiple Etiologies Dementia Committee. And really the focus of Detect CID really sprung from this notion that a top priority really is to come up with pragmatic approaches to objectively detect cognitive impairment with a linkage to quality care. And that's really an important kind of highlight message, that it's about detecting it and knowing that you have a plan in place to move forward with the patient with turnkey recommendations. And also recommendation 2 has also been a real focus on, whether or not we can, think about whether we eventually get to universal screening, which we kind of have already with annual Medicare wellness visits. Do we think about whether or not there's any potential harms, in particular psychological harms to individuals, especially those who might not have a pre-existing cognitive concern, if they were to be exposed to screening? And so some of that work we've been trying to do together as part of this consortium. Again, some of the premise for these two recommendations and where our work has moved forward so far is that primary care settings we know are well positioned to detect cognitive decline, yet oftentimes it goes undetected. And in 90% of cases of mild cognitive impairment, which is a major focus of the current initiatives in thinking about early detection, almost all the time these cases are missed. And that's a lot of times due to not just the primary care practices themselves, but the measures that and whether or not they're capable of capturing that. And the need for, again, brief, also EHR tethered and easily administrable tools is what have been kind of the basis for a lot of these recent calls for research among NIH specifically. Our colleagues at UCSF, Kate Pacina and team, have also highlighted disparities in terms of timely detection and also workup, specifically among Asian, Black, and Hispanic adults. So addressing health disparate populations and early detection has also been a key issue for us. And so again, the consortium started in 2017. We've been working with two other groups, Albert Einstein in New York and UCSF. We're the three groups that represent the consortium nationally, and each of us have developed different approaches. The Northwestern team, really led by its international leadership working on the NIH toolbox. And here is our team. Just wanted to highlight, throw it to Richard Gershon, Cindy Nowinski, Stephanie Young, Lee Wayo, and Mike Bass, and among faculty and others that have been really leading the NIH mainstay effort to data harmonize around cognitive function assessment across research. And so this initiative has allowed us to create clinical utility of two of the assessments within the NIH toolbox that have been able to kind of be captured as a screening tool that could work in primary care. The tools are just as a showing, the two measures, a memory assessment and an executive function measurement, are administered in iPad. They're self-administered, and they also auto-populate in Epic. So these are tools that we've designed specifically with primary care practice feedback over the years. And now that has led to where we're at right now, a MyCog, as we call it, primary care paradigm, in which we're trying to now start to identify individuals who are showing signs of cognitive decline or even impairment, and specifically linked to annual wellness visits. So this is kind of just our algorithm for, in current activities. For those who are less familiar, the annual wellness visit funded by Medicare requires a cognitive assessment. So in some ways, there already is universal screening happening. To that regard, how well cognitive function or cognitive dysfunction or impairment is being picked up is mostly viewed as suboptimal. And so for us, trying to ensure that there is not just better detection tools like what we're putting in with MyCog and what UCSF and Einstein are also doing, but once an impairment is detected, that there are more turnkey recommendations to really promote referral, and also AMA recommended practices with regards to ruling out reversible causes, reviewing medications, considerations for also non-medical referrals and services. So trying to have that in place to have a structure for primary care so they feel mobilized and empowered to move forward with anything that is perceived as being an anomalous test performance. So we do have two ongoing large-scale trials underway with the MSS team. And right now, one is NINDS and one is NIA, and both are large-scale practices, cluster randomized trials, pragmatic trials that are being performed right now that are looking to see if we can improve rates of detected cognitive impairment, and specifically expecting a higher proportion of those being MCI or mild cognitive impairment. And if we can actually make headway in reducing disparities in detection as well. in addition to get there, we know that we also have to improve referrals upon a positive screen, and ultimately getting to a more standardized diagnosis, and also, if possible, involving care partners as early as possible. And we have fidelity outcomes as well that'll be in place, so we can start to understand from a primary care perspective what are the costs and pain points of implementing this, so we can best get this to scale. Other initiatives that are going on that I'll just quickly mention is also led by Cindy Nowinski and Richard Gershon, is the MyCog mobile assessment. So taking the tool even one step farther, and it's working on a smartphone version where you can imagine actually assessing cognitive function from afar for an annual wellness visit or anytime a cognitive impairment is suspected. And so that is a start that's going right now. And also wanted to give another head nod to Stephanie Young, who's done a lot of the groundwork for developing this tool, among, again, many others on her team. Another thing to note with Laura Curtis in our group is EasyCog, a project out of Mount Sinai, one of our Pepper affiliate institutions. And this is using natural language processing applied to combined with automated voice collection and capture to determine if you can actually suspect cognitive impairment, and also do something similar, but again, using really predominantly through electronic health records. So that's a really exciting project that I think is a new route. And that's Alex Fetterman and Juan Wisniewski, as well as Lily Chan, all faculty in the School of Medicine there that have been great collaborators that we've been happy to be able to partner with. And finally, as I kind of wrap up here, and sorry, I'm going through a very large kind of research agenda within our group, but I really wanted to highlight maybe on a higher level some of the really interesting work that's going on. Rachel O'Connor, who I mentioned before, has been doing some great work and really kind of innovating around thinking about caregiving in the context of not just multiple chronic conditions, but when there's the added diagnosis of a cognitive impairment or Alzheimer's disease or related dementia. And so she's doing the deep dive there and starting to understand what's really going on in those dyads and how to optimize that work. So very excited to see her leading that initiative for us. Minji Kim, based in neurology at Northwestern, is really focused on sleep health and really understanding how not just again, aspects of sleep disorders, but thinking more broadly about sleep disturbances across a range of it and how that impacts cognitive function and ultimately self-management in chronic conditions, given it's so prevalent. So that sleep cog study is something we're really excited to be able to partner with her on. And finally, Rebecca Levitt in clinical psychology in our also in Division of General Medicine is doing some great work on primary care universal screening. Understanding, trying to unpack that recommendation one from the ADRD summit about whether or not there is any potential for psychological harms, particularly among individuals who might have walked into an annual wellness visit thinking that they were fine, and then realizing that maybe they have an abnormal screen, or even if they didn't have an abnormal screen, what is the impact of going through routine screening, and whether or not that could be something in the near future to aid efforts for early detection. So with that, I'm going to pause, and I kind of ended a few minutes early. So if there's any questions or any opportunities to discuss the work further, I'm happy to chat. But thank you for joining the talk. I don't know if Sarah had to step out, but if there are any questions, I'm happy to, if you want to drop them in the chat, I'm happy to make any acknowledgements of it. Or feel free to chat.
I have a question. Great talk. I'm Kala Raji from University of Texas Medical Branch, Galveston. And my question relates to the newly approved medication, the monoclonal antibodies, Leqembi or lecanemab. How do we you've already sort of elaborated on the multiple domains that impact access to care, adherence to care, and attitude to care. How do you put these within that, given that this medication, as you know well, is approved for MC and the early stage of Alzheimer's disease? How do all these multiple domains, and what are you hearing from the caregivers, as well as care partners, as well as patients, with respect to this particular medication?
It's a great question. So all these new monoclonal antibodies that are coming out, and there's many more that, behind them, to think about. I think even what we learned in the earlier rounds of less successful FDA-approved treatments, that there was a lot of reticence regarding their use, even though there was clearly an interest. And so I think it's going to be a challenge for a lot of healthcare systems on how to communicate what we know about them, what the expectations for treatment and benefit could be. How do you involve care partners, to your point, in the mix for it, to make sure that if they are to get the optimal treatment, that they are taking the medications as prescribed and safely, and that they're surveilled properly. I think all those issues, I think, probably, to my understanding at least, because it's still so new, is that I think you see more questions than answers with regards to how this is being played out, and so I oftentimes, especially I think our first example in the first round of treatments that we saw as they came out, there was a lot of places basically just saying no, that this is not a treatment that we're offering at this time because of the concern for whether or not it truly showed as much benefit. Now, these current rounds seem to show more benefit, although the benefit still seems muted to a degree. That might be an arguable comment, but I would be curious, I think, to the context of what I've been talking about today, I think it'd be really important to prepare ourselves moving forward for how these discussions happen with families, not just the patients, but also if they are to be prescribed, how their adherence and their safety is ensured. And also, again, I think the shared decision-making point altogether is a very important one, and it probably should be thought out sooner versus later. So I have not seen like a very clear, org chart or basically any kind of algorithm for how that all happens, but I'm assuming that might be the case. I think obviously there's a lot of interest and demand for these new treatments, and that's only going to grow given this has become the anxiety and the phobia around these is so high for patients, especially in the early stages. And that's why I think also recommendation 2 exists for the ADRD summit, is because of the potential psychological harm of even suggesting that you have a diagnosis, that people are going to be quite mobilized to try anything to if it can circumvent their progression of the condition. I don't know if I covered you completely on that, but I think there's a lot of unknowns is probably the best way I can say it.
It looks like there's a question in the chat. Amisha Walia asks, has there been testing of how long some of these tests take in clinical workflow and implementation barriers and facilitators?
That's a great question, Amisha. Glad you made the call. Great to hear from you. That's a perfect question, and that is something that our team, again, working with Richard Gershon and Cindy Nowinski and all of those who have been doing all this great work with the NIH toolbox, in choosing the assessments, even there's a lot of, we've been working for the past since 2017 directly with clinicians, especially in primary care, what is acceptable. So our assessment takes less than 7 minutes. How do you fit 7 minutes in? Does that happen before a visit? Can it fit within an encounter? Some of the things that we've done to kind of offset the time has been making it self-administered, and also in trying to create that tethered, so auto population, so no manual data entry with results. That said, if you're going from a mini cog that just takes a couple minutes and a clock drawing, versus to a 7-minute test, that is not, clearly that's still something that has to be worked out. So offering practices maximum flexibility for thinking about how they can incorporate these tests is kind of paramount. I think that's also the justification for the MyCog mobile, like being able to do it before a visit is another key aspect. So time, I think, is absolutely critical towards whether or not it can be implemented successfully and sustained. So we are right now live with 15 practices at Northwestern, and we are about to go live in the next couple of months nationally with our Oak Street Health partner. So I think this has become a lesson of implementation science, absolutely.
Do you have any other questions?
Okay.
Just one question about the EasyCog. Is it the natural language processing? Is it ready for prime time? Because I could see how that can help with respect to early recognition of any change in cognition. I mean, from the perspective of better management of multiple chronic conditions, more so than starting to use the monoclonal antibodies. Is it ready for prime time, or is it still under development?
So this is where I get to I get to say that is a great question to direct to the Mount Sinai team, who's really been leading some really cool efforts with it, and Alex Federman and Juan Wozdeski in particular have been very thoughtful about this. It sounds like Giselle is saying it's still under development a bit. They're working on this. This is the whole grant that they have right now, and I know they're not the only ones working on these types of tools. So my guess, the question would be that it's a work in progress is absolutely sure. And Laura Curtis in our division is site PI for the project in its work at Northwestern, working with Giselle Wismer. And so it's in validation right now. So I think we're going to find out very, very soon how well, that does work, given that there is a bit of dependency on for the NLP work. It depends on what's in the record that can be captured well, and how well there's documentation that's even put into place. So it's going to be done on a large scale, but we'll be finding that's in the works. So sorry, I can't be more informative as to where we land with it, but stay tuned. And thanks for the interest from the UTMB Center. I enjoyed going out to see you all not so long ago.
Okay, thank you very much. Great talk. Thank you.
All right. Do we have any other questions today? Don't see any.
All right.
All right. Well, thank you so much, Dr. Wolf, for your talk. We really appreciate it.
Great. Thank you so much. Happy Friday, everybody.
Bye-bye.